So how do we deal with this? Well, you have some very, very good programs here and more that are planned. You heard today about some of the mobile outreach programs. So when we move from heroin to addiction, addiction to injection, injection to risk for infection, how do we stop that pathway? We do outreach, and you are already doing that in some of the programs here. It sounds like there are plans to do more. Getting out to the streets with persons who know the streets. In fact, with our program for the homeless and with Dr. McCoy's many years of programs, we almost always had ex-addicts, people who had been addicted before, had been active users, knew the street. Often they had been homeless before. They knew the people, they were believable, they could talk the talk on the street. And they were the very best people to get out and bring people to the program or bring the program to the people. Much of the focus was on harm reduction, distributing condoms, teaching people how to bleach their injection equipment. Studies from San Francisco and elsewhere years ago demonstrated that if you're able to bring 2 syringefuls of bleach into your needle, so after using it, draw 2 syringefuls of bleach, shake it for 30 seconds. Shaking doesn't do much. Shaking takes the time of a drug user who might start to feel the withdrawal symptoms. So have them shake the syringe for 30 seconds and squirt out, the street name is skeet out the Clorox or the bleach, and then pull up another full syringe full of bleach and keep it there for 30 seconds, squirt it out again, not quite yet, not ready to inject yet. You don't want to inject bleach. Go to water now, clean water, do 2 syringefuls of water, pull them in, shake them, squirt them out, another syringe full of water, shake it, squirt it out. Now you're ready to inject. The interventions are of various sorts. The earliest interventions were HIV testing. Now we can do very rapid testing on the streets and have the results within several minutes. So we don't have to have people come back for results or not know or have to find them. We can tell them within 30 minutes or less what their HIV status is. We can do education in terms of risk reduction. We can make them aware of services available. We can give skills training like bleaching, using condoms, safer behaviors, and we can tell them about available treatment when they are ready. We need to follow them up. So the protective behaviors are don't do drugs, but most drug users have a hard time with that at first. Reduce drug use. Clean your needles. Don't share your needles and syringe. Clean or use new cookers and new cottons. Only use the bottle cap once. Only use the cotton once. Only use the wash waters once and never share them. And use barriers, male and female condoms when you have sex. As far as sexual risks, oh, by the way, this is an important point. In the United States, and this was a point that was made by several speakers this morning, there are not enough specialists like toxicologists, but what we're doing in the United States now is there's a major program called ESPERT. It is being trained to medical residents. It is being trained to nurses. It is being trained across the country in primary care centers, the people most likely to see drug users, including drug injectors. It stands very simply for screening. Screen for drug use in primary care. Brief intervention. Do it during the clinical session when you're seeing your patient. And referral to treatment. ESPERT is becoming very popularized. It is in most every state. It's in many medical schools. And just as you are about to have, I think it's 1,000 medical care providers in Bogotá looking for people who use drugs. In the United States, we're really trying to become very savvy to screening. And some points that were made today, it's not just for drugs. In fact, the major use of expert is alcohol. Because like here in Colombia, one of the major drugs of use and misuse for which we can screen and for which we can treat effectively is the use of alcohol. So it's not just the heroin issue, it's not just the far tail of the group of people who do not just alcohol, but drugs, not just drugs, but drugs by injection. This works for the whole spectrum of drugs. In terms of sexual risk interventions, they look like this. Abstinence is perfect safety. If you don't have sex, you won't get infected sexually. Nobody does this. Reduction of sexual partners, very important. Condom use or barrier protection. And again, it differs by culture. In our homeless project was based at an NGO in Miami called Camila's Health Concern. Camila's House is a major residence or set of residences for homeless people, and Camila's Health Concern is the clinic that goes with it, set up by an absolutely brilliant physician who has won international awards for helping the homeless in terms of healthcare. Camila's Health Concern is within the Archdiocese of Miami. We distributed in the first 5 years of the program millions of condoms on the street. Then the bishop changed. And next month we distributed no condoms at all. So it will depend on the culture. Several people here may have the same viewpoint that barrier protection is not appropriate, and so there will be some resistance. And there certainly was with the Catholic Church for our project in Miami. So not every one of these strategies works in every place with equal application or acceptance. But again, as you tailor it and modify it to the culture of Colombia, these are things you're already doing, and these are things you can continue to do as it fits for your use here. Negotiating for safer sex, and also, very important, suppose a person's HIV infected. This is very hard. In fact, clinicians are working very hard. There is major research underway. How do doctors who treat people who have HIV infection help their patients tell their sex partners, I'm HIV infected? They may be fearful that the person will actually be aggressive toward them. They may be fearful that that person will certainly not have sex and may actually be very angry and end the relationship. It's a difficult thing to disclose you're HIV infected. But the fact that you're HIV infected means that you are carrying a potentially lethal pathogen. Your partner needs to know this. It's a tough lesson, and it takes a lot of support. Increasingly, numbers of people, particularly because we do have effective HIV and AIDS drugs. HIV and AIDS has now become a chronic disease, not an acute death sentence. And so for people who actually maintain their medications, they will have a very low viral load. Many of them can have sex in a very satisfying relationship, and they will not be placing their partner at much risk, but their partner should know. So it's dependent on disclosure, telling people you have HIV, keeping up with your medications to maintain a very low viral load so you are minimally infectious to your partner, using barrier protection every time. And finally, how about the seropositives? The wording that comes out right now is called STTR, seek. Find the people who are HIV infected, test, verify that they are HIV infected, get them into effective AIDS treatments, and retain them in treatment so they keep their viral load low, keep their health high, and do not infect anyone else. Evaluation is also very critical. We are looking at science-based interventions. Assess risk over time. Is your program working? What's happening with your infection rates for HIV or hepatitis? Are they staying stable or ideally going down? Are your persons in treatment or in intervention reducing their drug risks? Are they reducing their sexual risks? And if they're in treatment for HIV, are they keeping up with their medications? So these are the things that come together in our presentation, and that's the conclusion of my comments. Thank you very much.